Hey everyone and welcome. We're going to do something really important today. We're going to take a critical checklist and turn it into a powerful mental model for one of the most high-stakes procedures in all of healthcare, intubation. And look, this is way more than just ticking off boxes. This is about building a fortress of safety around your patient.
So let's just jump right in with a scenario every nurse dreads. The patient is crashing, the SATs are dropping, the pressure's on. What is your first move? What do you do right this second?
Well, here's the thing. The single best, most life-saving move you can make doesn't actually happen during the crisis. It happens in the minutes leading up to it. Success here isn't about frantic action. It's all about meticulous, proactive preparation.
So let's get into it. Let's talk about building that safety net. This first phase is all about creating this protective buffer, this cushion for your patient before the laryngoscope is even picked up.
And a huge piece of that safety net, honestly, it's a total game changer, is apneic oxygenation. Just think about it. By running high-flow oxygen through a simple nasal cannula during the attempt, you're passively flooding the lungs with oxygen. This one little step buys you precious time and dramatically reduces the risk of the patient's oxygen levels plummeting. Now, you might look at this list and think, yeah, that's standard stuff. But let's break down why each one is so crucial. Getting monitors on before any drugs are given, that's so you can catch hypotension the second it happens. Pre-oxygenating for 4 whole minutes, you're not just topping off their O2, you're literally washing out all the nitrogen from their lungs to create a huge oxygen reserve. And that patient positioning, getting the ear at the sternal notch, actually lines up the airway structures. It makes the whole procedure way easier and safer.
All right, safety net is in place. Now we move on to the next critical phase, getting our drugs and devices ready. Think of this as building the bridge that's going to get you to a secure airway, and there is absolutely zero room for error here.
These 4 categories of drugs, they are completely non-negotiable. I mean it. It's so easy to just focus on the induction agent and the paralytic, but you have got to have your post-intubation sedation ready to go to prevent awareness, and you absolutely must have emergency pressors drawn up and ready to fight that inevitable drop in blood pressure.
I know. This seems so basic, right? But this is such a critical safety step. Verbally confirming the drug and dose as you draw it up and slapping a label on every single syringe, it's a simple, powerful action that prevents devastating medication errors, especially when stress is running high. This right here, this is a huge mindset shift. Post-induction hypotension isn't a surprise. It's an expected side effect. Especially if you're using something like propofol or if your patient is septic. Your job is to anticipate it. Having that push-dose pressor right there ready to go means you can treat it instantly, not after a delay. Let me be really clear about this. A failed intubation because the laryngoscope light is dead or the tube cuff has a leak is a completely avoidable catastrophe. This sequence is your guardrail. Check the bag valve mask, check the scope, check the cuff, and have your backups right there, within arm's reach. Okay, so all our gear is checked, drugs are labeled and ready. Now we have to deal with the most important variable of all, the human factor. This is all about making sure every single person on the team knows the plan, what their job is, and exactly what to do if things go sideways.
And this right here is the heart of that team briefing. Everyone needs to verbally confirm that they understand these backup plans. What's our plan A? Okay, if that doesn't work, what's plan B? Immediately. What's plan C? Having this conversation eliminates hesitation and allows the team to move decisively from one step to the next if the first attempt fails. This kind of structured communication just wipes out confusion. Who is pushing the drugs? Great. Let's hear a verbal readback. Who's holding C-spine? Who's in charge of inflating the cuff? By sorting out these little details beforehand, you make sure that when every second counts, the team works like a single, well-oiled machine.
And here we go. We're in it now. This is the climax of the procedure. This is where all that preparation gets put to the test, and where you, as the nurse, have to be hypervigilant to spot and react to life-threatening problems. If you see this number pop up on the monitor, that is not just data. That is a 5-alarm fire. It signals severe, life-threatening hypoxemia, and it demands an immediate, standardized response that starts with your voice. This 3-step response is your emergency brake. It's a reflex. You call out the number, loud and clear. You announce, stop the attempt. And you immediately go back to bag mask ventilation. This simple, powerful sequence hits pause on the crisis and gets the patient's primary safety net back in place, oxygenation. As a nurse, your role in spotting these risk factors early is just so important. You're at the bedside. You see the patient with a thick neck or a history of sleep apnea. Your job is to raise your hand and advocate for opening that difficult airway cart before it becomes an emergency.
And really, that's the ultimate takeaway here. When an intubation goes smoothly, it looks calm, almost routine. But that calm is never, ever an accident. It is the direct result of the meticulous, proactive, and vigilant preparation that you, the nurse, put in during those critical minutes before the procedure even started. That preparation, that is what truly saves lives.